let's get started. I want to thank you and welcome everyone to this special I3 session. My name is Jullin Fjeldstad. I'm a clinical embryologist and previous lab director turned head of clinical embryology and scientific operations for Future Fertility. So my role with Future Fertility is working closely with partner clinics to ensure smooth onboarding of our AI tools. However, today we are talking about the evolving global landscape regarding egg banking. So this session will bring together expert voices from a range of international egg banks to share their practical knowledge and insights, emerging trends, and evolving best practices in this rapidly evolving field. So I'm really excited to hear all about this. So join us for a valuable exchange of knowledge and a chance to gain some fresh perspectives from busy banks shaping the future of egg banking. This webinar is kindly sponsored by Future Fertility, and I'd like to introduce my colleague as co-host, Rafael Gonzalez. He is our head of global sales and business strategy. He also has a long-standing experience within the IVF field, having previously been Chief Commercial Officer for an egg bank himself, Ovobank, and will provide some great insights regarding the lectures and whatnot today. So I'm looking forward to some great discussions. So I'll pass it on to Rafa.
Thanks a lot for the introduction, Jullin, and I'm very happy to be co-hosting this event. I'd like to introduce two expert co-hosts with us tonight. Firstly, we have Skye Green, who manages Vitalab Egg Donation Agency, VIDA, in Sandton, South Africa. She has an advanced specialist fertility counseling diploma and over 5 years of experience in IVF coordination, facilitating seamless matches between egg donors and recipients. We also have Yannis Panagiotidis, laboratory director at Yakentro IVF clinics in Greece, with years of experience and earning his PhD with a focus on the vitrification method for the cryopreservation of human gametes and embryos. So guys, welcome.
Thank you, everybody. Kindly note that we will keep the bios short this evening, but the full extensive resume of the careers of the experts for tonight's session can be found on the I3 website. Please go and have a look there. And then kindly note that when you have a question, please can we ask that you place it in the question section of the portal and not the chat function. So please do not use the chat function for any questions, but do place it in the Q&A section. Thank you.
Okay, so without further ado, it's my pleasure to introduce our first speaker, Dr. Deanna Guidozzi. Dr. Guidozzi completed her Bachelor of Medicine and Bachelor of Surgery in 2010, followed by her fellowship of the College of Obstetricians and Gynecologists of South Africa and her Master of Medicine in Obstetrics and Gynecology, both in 2020 at the University of Witwatersrand. In 2022, she earned her membership of the Royal College of Obstetricians and Gynecologists. And she also holds a Master's in Biotechnology of Human-Assisted Reproduction and Embryology from the University of Valencia, Spain. And now, as part of Vitalab team, she specializes in obstetrics and gynecology, and she's driven by her passion for helping families grow. So Deanna, please, the stage is yours.
Thank you. That's absolutely wonderful. Hello, everybody. It's a real pleasure for us to be part of this. Thank you so much to the I3 organizers for including us, and thank you to everyone who has taken the time to join. So the title for my talk tonight is Exceptional Choices, Cracking the Code of Egg Donor Screening. Just to offer you a little bit of background, I am one of the doctors from Vitalab in Sandton, South Africa. We do have two branches, one in Johannesburg, Gauteng, and the other one in Umhlanga in KwaZulu-Natal. We do have our own egg donation agency, which is called VIDA, and we're very proud because it is the first and oldest egg donor bank in South Africa, where we offer both frozen and fresh donor oocyte packages to all of our patients. So donor screening is essential for us in order for us to protect our recipients from potential disease or harmful exposures, to protect our donors from iatrogenic harm, and as a result, to protect our future offspring. Many guidelines and articles have been released over the years to assist with suggestions on screening and gamete handling. These do vary in part from region to region, but there tends to be three main pillars that form the foundations of these guidelines. So if we look at it, mainly the first pillar would be the medical screening, which we usually do for both our recipients and our donors. This includes a physical exam usually and a gynecological exam, which I'll go into a little bit more detail around. We always do psychological screening in order to assess the psychological readiness of our donors, as it is a challenging process and there obviously are long-term consequences. What underpins all the guidelines, though, is the emphasis on maintaining ethical standards in order for us to maintain a high quality of care. Although there are many guidelines available, probably the most influential would be part of the American Society of Reproductive Medicine, or ASRM guidelines. These are very comprehensive guidelines that cover oocyte donation, sperm donation, and even embryo donation. It also does include FDA safety protocols and assists us with regards to what tests we should be considering. ESHRE does offer guidance to European countries as to what those standards should be, and it's also a very comprehensive guideline. RCOG and HFEA would be the bodies that control donation within the UK. So, as I say, guidelines do vary significantly from country to country and regions apart, but there are main pillars that we do consider. And in South Africa, we have our own law around our donation guidelines. We do take from the international guidelines in order to follow our own guidelines. So in our country, the laws that are important would be our National Health Act and our Children's Act, which regulates gamete use and artificial treatments in our country, as well as our donor relationships and donor handling. We also have our own South African Society of Reproductive Medicine and Gynecological Endoscopy, which has produced a guideline for egg donation agencies. And this document is a good summary for all agencies and guides us as to who we may accept as donors. It guides us as to advertising and funding as agencies, the number of donations that are allowed per each donor, and the number of live births, as well as the issue of anonymity, which can be very different, as you know, between the varying countries. Reimbursement is always covered in the donor guidelines. The overall feeling is that donation should be maintained as an altruistic act, although reimbursement is allowed in some form, and usually this would be reimbursement for a donor's travel, their expenses, and obviously their assistance. But it is in no way meant to be an incentive or coercive. So looking more closely at our different essential screening components, as I've said, the first part would be looking at medical history and the physical exam of the donor. So she should maintain or be part of the legal age requirement that is usually between the ages of 18 and 34 in most countries. In South Africa, this is part of our age spectrum, although we usually say between 21 and 34. We can use ladies who are younger than this, but they should have some form of very special assessment, let's say, beforehand to ensure that they are mature enough and so on to be doing this process. All donors do fill out a medical and family history questionnaire so that we're able to assess for heritable conditions, and then obviously to have their physical examination, which is usually performed by a doctor, and this is done before acceptance, and then usually every 6 months while they are available to assist with donating. So as I've said, the gynecological examination should be comprehensive. This usually involves an ultrasound, which will assess the uterus and the ovaries and look at antral follicle count and for any concerns around pathology. Obviously, the rest of the physical exam includes BMI, evidence of substance use, evidence of infectious diseases. And along the same vein, we then do serological testing, and this is also very standard among the guidelines, especially testing for things like hepatitis B, hepatitis C, syphilis, and HIV. Some of the guidelines, specifically the FDA, also suggests testing for chlamydia and gonorrhea if indicated, and even West Nile virus. All the guidelines do suggest a time frame in which these tests should be done, and this is usually 30 days prior to an oocyte retrieval or within 7 days after the extraction. And this is obviously so that we remove these our oocytes at a point in time when we know that the donor would be free of any infection that could affect our recipient. A psychoeducational assessment should always be done by a qualified licensed mental health professional, and this is usually done with an interview and a validated assessment of their mental and assessment for mental and behavioral disorders. So part of that mental health history would include obviously a personal history for that donor, but also looking at the first degree relatives, if anybody else in the family is known to have a history of psychiatric illness. Further investigation into whether there has been a history of abuse, history of trauma, if there has been a history of substance abuse or issues with the law, and even broaching the subject of why this person wants to donate would all be important to explore in this particular interview. In addition, understanding of the donor around the process and around what they're doing would be important to explore, as they need to understand the implications of what they're doing and the possibility of assisting multiple families and having multiple live births from this process. The other issue would be that most countries do offer the option of having anonymous donations still at this stage, although there are some countries moving away from this. But in this setting that we currently have with regards to internet and social media, there needs to be a level of understanding that in the future it may happen that the donor's anonymity may be breached, in the sense that through social media and internet sites such as 23andMe, where donors are able, or donor-conceived children are able to pass DNA through and get it assessed, they're able to trace their possible donor parent. So that level of anonymity is breached. Okay, so who would be excluded? So patients or donors based on physical findings where we see physical evidence of sexually transmitted illness, either on the exam or on their serological tests, donors who may have underlying medical or gynecological disorders that either would impact on their ability to donate or may be worsened from the donation process itself would be excluded. Those, as I've discussed, who have underlying serious mental illness, or those who have first-degree relatives with serious mental illness, those donors who are on significant psychoactive medication or have history of substance abuse, even relationship instability or high-risk sexual practices may be excluded from the donor process. In addition, we always need to consider high-risk patients or high-risk donors, and this would be donors who have very high AMH levels or antral follicle counts or histories of polycystic ovarian syndrome, which would mean that they have a high susceptibility to ovarian hyperstimulation syndrome. So this would then be a dangerous project or process for the donor to be part of. In addition, we need to consider donors who may have exceeded the number of donations which they are allowed. So again, this varies from country to country. In South Africa, we limit our donations to 6. We don't like to do, or we choose not to do more than 4 in a 12-month period, and we certainly don't allow back-to-back donations. This is probably in keeping with a lot of the guidelines. The ASRM also limits it to 6 donations and 6 live births, unless in certain scenarios where we are assisting a family who already has a donor-conceived child, and we're providing or helping assist with a sibling for that child. The same goes for donors who have exceeded their maximum number of live births. So there is a limit on this, and again, varying from country to country. In places like China, the limit is apparently 3, and in some countries they limit it to families as opposed to live births. So in Taiwan, apparently that is limited to a single family. So this all brings into play the need for a central database for our donors, our recipients, and our donor-conceived children. So in theory, this is a very good system, which we would all benefit from. But in reality, it can be very difficult to establish and certainly to maintain. So we cannot talk about donor screening without covering the contentious issue around genetic evaluation. So this is not something that is universal, but there are many countries who are considering the expanded carrier screening of their donors. And the main drive for this seems to be the fact that agencies and fertility clinics would obviously like to provide their recipients with the safest and best options that are available for those particular couples. So currently, certainly the ASRM does recommend testing all donors for mutations that can cause cystic fibrosis, spinal muscular atrophy, thalassemia, and the other hemoglobinopathies. So this probably stems from some research that was done, carried out by 16 companies who were using expanded carrier screening. And in that, 17.6% of donor candidates were excluded owing to their carrier status for one of these conditions. When wider testing was done, this did not exclude more donors. So this may call into question the need for larger genetic panels if this is truly necessary and if this would be appropriate. So as I said, it seems that mainly the cost of egg donation and the need to enhance donor profiles may be what has precipitated the need for this genetic evaluation. So in order for us to try and offer our patients the best available options for them, the additional testing can be done, but that's usually based on family history. So otherwise it is the expanded carrier screening, as I've discussed. Beyond the US, requirements for donor screening do vary widely by country and are linked to how gamete donation is regulated and reimbursed. So just some thoughts. If we are doing testing for these recessive disorders, which may have a significant impact on the life of a donor child, a donor-conceived child in the future, should we not also be considering some of the autosomal dominant conditions that do have an impact later in life, such as BRCA? And if we are going to be including these large numbers of genetic conditions that may occur, does it also not mean we may not be placing an unnecessary burden on the donor herself, on her future children, and even on her relatives, her extended family? So, as I say, does this not possibly create an unnecessary burden? And if we do respect a donor's wish not to know about the outcomes of their tests, will this not cause possible moral distress for the person who does have the information and the doctor who is unable then to possibly give this information to the donor? So this is something to think about. This was a little paragraph from a document written by the American College of Medical Genetics in 2013. They had said, in the context of incidental findings for patients undergoing whole genome or exome screening, that staff possess a fiduciary duty to prevent harm by warning patients and their families about certain incidental findings, and that this principle supersedes concerns about autonomy, including the right not to know. So it does create a little bit of moral conflict for the doctor and for the donor. So if there is information that the donor would rather not know, is the doctor still morally obliged to tell that person? Okay. Additional consideration. So if we are doing this screening, are we possibly at the potential for exclusion in the future from certain insurances? And is it fair that we do have discrepant law, possibly, around testing for donors and recipient or recipient partners? We don't automatically test our recipients. And should we not maybe be considering alternative options for testing? So in other words, maybe testing our recipients first and then basing our donor testing on these findings. There is a model of expanded carrier screening that is used for Ashkenazi testing called the Dor-Yeshurim model. And in this case, both the donor and recipient are tested, but are both blinded to the results. So they only know whether they are compatible or not. No information is revealed about the underlying conditions. So this might be a way that we avoid kind of the moral difficulty of having information that donors may not want. So looking more closely at our South African regulations, specifically that apply to VIDA, so our egg bank, we do look at donors between the ages of 18 to 32, but as I say, if we're using donors under the age of 21, they do have extra assessment to ensure that they are mature enough, let's say, to go through the process. We do family and medical history questionnaires. We assess their chronic medication. We only require a school leaving certificate for our candidates. We look to ladies who have a BMI of less than 31. All our donors are screened by a doctor, and that includes an ultrasound of the uterus and the ovaries for an antral follicle count. We do HIV, hepatitis, syphilis on all our patients. We also include a blood group, but only do an AMH when it is necessary or requested by the doctor. And all of our donors do receive psychological screening by our social worker. Interestingly, we don't force our recipients to have psychological screening, but this would certainly be of benefit. We don't offer any specific genetic testing unless it is requested for. So this was more just out of interest. This is a little table that shows the worldwide variation in availability of ART or treatment. So interestingly, even kind of within the same region of Europe, there are quite differing guidelines or rules, laws around availability of treatment. The reason I chose the categories that you can see there on the left-hand column is because they mainly kind of relate better or more to the availability of donor oocytes and who that would be available to. So it is also interesting at the bottom, you can see the difference between anonymous and non-anonymous donation. So as I think everyone is aware, that the UK brought in new law to create an option for donor conceived children in order to find out about their donor parent from the age of 16, and then all the information from the age of 18, and Portugal seems to have followed. The rest still seem to offer both options to their patients. Okay, and then funding for ART also differs between countries. Most offer a combination of public and private funding. Some almost exclusively have privately funded ART, and South Africa falls into that category. So unfortunately, it does mean that there is great disparity in access and care with regards to availability of ART. Okay, so in conclusion, all guidelines do emphasize responsible screening for optimal outcomes of donors. And this includes, as discussed, the medical assessment. So this is the physical exam and the serological tests. It involves mental health evaluation from a psychological perspective in order to also assess the donor's understanding and offer her counseling around the process. And then the option for genetic testing in those countries who are offering that. And then finally, the golden rule of donor screening: never prioritize commercial interests above donor or recipient welfare. Both are our patients, and we would like to offer ethical, safe, quality care to everyone involved. Thank you. So I'm happy to answer any questions with Dr. Yossi Unterslag, who will also be joining us at the Q&A session. He is our director of VIDA, so he will be here. And thank you very much for your time.
Thank you, Deanna, for that insightful presentation. It was a great start to our session tonight. Before we move, I'm sure there will be many questions at the end during the Q&A session, and please put your questions there, everybody. Before we move on, I'd like to ask you a quick question about how do you check about the limits? Is there a registry in South Africa about if a donor exceeds the family making number when they are interviewed? How do you check for that?
Sure. So we are meant to have as part of the law and the guidelines. So I'll be honest, I'm not quite sure how well the registry works. I think, as I say, most places probably have the same problem as us, that in an ideal world, we should have that. But in practice, it's very difficult to have a central database and to maintain it. So Skye might be able to actually help me answer that question. So my understanding is, yes, we should, but in practice, no, not really. Yeah, if Skye has anything more to add from her side. Yeah.
Thank you, Doctor. So we do, each agency keeps their own record, and then should a donor disclose that she has donated elsewhere, we would then approach the other agency and ask for the outcomes. So it is heavily reliant on what the donor discloses. And we do also heavily rely on the counseling session that the donor has for the assessment, because the social workers and the psychologists are very good at ascertaining whether or not the donor is forthcoming with her information and is a trustworthy person. And so we do try and keep track of the donations that each donor comes through our door, but it's not a foolproof system, unfortunately. So I think all the agencies do have to get together and just work side by side to have that going on. Maybe when Dr. Unterslag has joined us later on, then he'll be able to offer more insight as well. Thank you.
So, but no central database. So thank you. Yeah.
Thank you both. So to move on with our webinar, it's now a pleasure to welcome our next speaker, Dr. Natalia Basile. Dr. Basile is a senior embryologist and development director at WeFib and WeBank, based in Buenos Aires, Argentina. She holds a master's in clinical embryology and embryology from Eastern Virginia Medical School. In 2008, she joined the EVRMA Madrid, contributing to both clinical and research roles. She has also completed her PhD in 2015 at the University of Rey Juan Carlos, with focus on embryo development and morphokinetics. Natalia, the floor is yours.
Well, hi everyone. My name is Natalia Basile. Thank you very much for joining me, and thank you very much for listening in advance. I will start my presentation, which is entitled What to Expect When You're Expecting Donor Eggs. Before I start, I have some disclosures. I'm an employee and shareholder at WeBank and WeFib, and I have nothing else to disclose. By the time that you're listening to this presentation, I'll be landing in Miami, so this presentation is recorded. Hopefully, by the time I'm done, I'll have passed customs and I'll have my suitcase with me and I'll have my headphones and I'll be able to answer all the questions. But if not, we'll see what we do. Okay, so what do I expect when I receive donor eggs? And I expect quality. I expect quality during the whole journey. I expect quality in egg donors. I expect quality in the oocytes from those egg donors. I expect quality in the results. And I also expect quality in the logistics. So we will go one by one through these points. So let's start with quality in donors. What do we do before the egg donation? And when a donor applies for our egg bank, the first thing that she has to do is she fills a form, or actually she responds to some quick questions over the phone. This will be questions about her age to see if she is within the age range that we approve for an egg bank. We will do some quick questions about her general health or her genetic history, although we will study her more deeply if she passes this first filter. And we will ask her some questions about her lifestyle choices. Just so you have an idea, from 100 leads that we get in our egg bank, after doing these quick questions, only 25% of the donors pass this first filter. When they pass this filter, then we will do some medical evaluation where this is a complete examination to see if she's in good health. We will do blood tests to see if they are safe from any infectious disease like HIV, hepatitis B, hepatitis C, etc. Of course, we will do an ultrasound to check her ovarian reserve. And if she passes all of these tests, we will move on to a psychological evaluation. We do have a psychologist on site that she works with patients, but she also works with donors to make sure that they understand why they are donating, what are the risks, and what's the purpose for her donation. If they pass our psychological evaluations, then we move on to genetic testings. In addition to the standard karyotype, we will do carrier genetic screening, and there's different companies that offer these tests. We do follow the recommendation of the American College of Medical Genomics and Genetics, which recommend to do 113 mutations. Here you see example of the most common ones. Although I have to say that very frequently we expand this carrier test, and we very frequently we tend to test the entire exome in our donors. Now, it's important when this is something that we offer, but it's important for the patients or the clinics to recommend whoever is contributing with a sperm sample to do the same test or similar test in order to take advantage of this information. And after that, there are some legal considerations, consents that the donor has to sign in order to enter the program. But the reality is that from all the women that have the desire to donate, only 5 to 7% end up donating. And the time frame between the first phone call that I mentioned before and the first donation is approximately 2 months. Okay, so the donor is evaluated and she has entered the program. So now we have to stimulate her. We use standard stimulation protocols. We use recombinant FSH, and if needed, FSH plus LH. The starting dose is usually 225. We don't stimulate aggressively our donors. Just so you have an idea, the average number of oocytes that we get per donor is around 16. Of course, there's donors with more eggs, but we try to maintain ourselves and not to stimulate very aggressively the donors. We do triggering with GnRH analog, or sometimes if the donor has less than 20 follicles, big size follicles, we can do dual triggering with ACG, 1500 units, or in addition to the GnRH analog. And sometimes the physicians, they choose, instead of using antagonists, to use progesterone. So what can we expect when we stimulate these donors? In this way, we should expect a certain number of oocytes, but most importantly, a certain number of M2 oocytes. And here you have month by month the number of oocytes that we retrieve from our donors and the number of M2 oocytes that we get. So we try to be above 80%, and these are numbers of 2023, where we retrieved more than 8,000 oocytes. Out of those, 7,230 were mature. This represents an 81.6% of maturity rate. Last year, even though you can see that we retrieved half of the number of oocytes, and this is because we became more selective in the donors that enter the program and the number of stimulation and the number of retrievals that we do. we did maintain the maturity rate. And the reason why we cut down is because we are very well stocked. We don't need to be overstocked with donors. So these are some of the considerations before we obtain the oocytes, which brings us to point number 2 of the lecture, quality in the oocytes, what we do during the donation. And as an embryologist, I am an embryologist. I don't know if I said it before. I worked many, many years in the IVF lab. And as you know, there's the oocyte has generally been evaluated through more standard morphological assessment in the inverted scope. Here are just some of the variables that we used to use, and we are still using them, but variables like the shape of the oocyte, the thickness of the zona pellucida, the size of the perivitellin space, the absence or presence of the polar body. And these are all characteristics that you can see with your bare eyes, and they are somehow prone to subjectivity, but we are still using them, and this is all we had until a few years ago. Today, with all the era of artificial intelligence in our egg bank, we are introducing artificial intelligence to evaluate our oocytes in a more objective and quantifiable way. And an example of this is a tool called Violet, which is part of the Future Fertility, which has 2 tools. One is magenta and the other one is violet. For egg banks or for fertility preservation, violet is the one that we're going to choose. And the technology behind this tool is the automatic segmentation through CNN of the oocyte in 3 main parts, which is the ooplasm, the perivitellin space, and the zona pellucida. The most updated version of this tool is called the ensemble model, and as the name suggests, it combines 3 prediction models, and it gives you a final output score according to the variable that you want to analyze. So in the case of Violet, you analyze the oocytes, and it will tell you the probability of generating a certain amount of blastocysts according to the number of oocytes that it's analyzing. So I brought you a small video just so you have an idea of how easy it is to use. The first thing that I want to say is that you don't need a time-lapse system to use these tools. You can take pictures. Here you can see them. I'll stop the video a little bit. You can take the pictures of the oocytes in your inverted microscope. Of course, it's easier if you have a time-lapse system because you can take all the pictures at the same time. But if you don't, you can still use these tools because you can take pictures in the inverted scope. And once you're done taking all the pictures, what you have to do is you tell the system to generate the report. And you'll see how quickly it generates the report. And I'm going to stop where it says the result. These were only 4 oocytes analyzed. And here you can see that Violet tells you that there's a 68.14 probability of generating 1 to 2 blastocysts. So this is information that you can share if you want to with the patient, or you can keep to yourself, and we can talk a little bit about this. I'm going to show you a real example with how we use this tool with a donor. Let's see the next slide. So this is a report. I'm sorry, it's in Spanish. We are in Argentina, but I'll walk you through it. This is a donor that had a lot of eggs. She had 38 eggs. So we applied Violet, and the system analyzed the entire cohort, and it said that there was an 86% probability of having between 12 and 20 blastocysts. This is useful information, yes, but am I going to donate 38 oocytes to 1 recipient? No. So what we did is we asked the system to split evenly this 38 oocytes into 3 different cohorts in such a way that the 3 possible recipients could have the same benefit or the same probability. So here you can see how applying artificial intelligence, you can quickly split oocytes from 1 donor evenly, and you have 3 cohorts with approximately the same probability of generating the same number of blastocysts. So We don't have to forget conventional morphology to assess the oocyte, but if possible, we have to welcome, or at least this is what we suggest or what we like to do, to welcome new technologies to make more informed decisions. Okay, so we have the oocytes, we have evaluated them, and now we have to cryopreserve them. As you know, manual vitrification is a very, very well established technique, but it does have a long learning curve. If you are going to have an egg bank, or if you're going to offer fertility preservation in your clinic, you must have a staff very well trained in terms of vitrification. And it's not impossible. Of course, as I said, it has a long learning curve, but it's not impossible. You can be a master in vitrification. But the same way, it's very easy sometimes to drift from the protocol, and very slight changes in the protocol can have very huge impact in the clinical outcomes. So we are still, and we will keep doing manual vitrification, but we are welcoming automatic vitrification as well. And here I brought you a video that you can see an embryologist using a device that is called a vitri to do automatic vitrification. Basically, this system, what it does, it's a disposable microfluidic biochip where you place the oocyte in the center well, and you will see how through inlet and outlet channels, the cryoprotectants are entered and as I said, it's not impossible, but as you know, the density of the cryoprotectants are different, and this can be challenging because the oocytes can float, and for an unexperienced embryologist, sometimes it can be hard to find the oocytes, and then it may take the embryologist longer to pass through, and this results in different results to whoever is vitrifying. So when you do this automatically, all the differences between one lot and the other. And here, the machine reminds you that you have to load the oocyte, and this is the only step that is done manually, which goes against automatization, I'm sorry. And this is a very important step in vitrification. This part automatically as well. So I'm waiting to receive this. Let me pass again. There. So what do I expect when I introduce automatic system reproducibility? We just received 4 or 5 more of these devices. So we are slowly moving automatic and doing it how. What are our results with the system? Was done with the automatic vitrification system. The survival rate was similar between the two systems. The fertilization rate was similar as well, but we did get a little bit more blastocysts when doing automatic vitrification. So, despite of the indication to vitrify eggs, whereas it's to create a donor egg bank, or if it's for fertility preservation, or if it's because you're doing an IVF cycle and the semen sample is not available, and despite the method that you use to vitrify egg, you must assure yourself a minimum survival rate. 80 to 85% is the global survival rate. If we are talking about the eggs from our bank. Which brings me to point 3, a lecture using our the majority of the cases get 9 oocytes. Then in second place, we have the patients that get 12 oocytes, and these are most oocytes. These are more conservative patients that they don't want to generate lots of embryos, or sometimes because there is and the reason why it's 6, 9, or 12 is just because we tend to vitrify the oocytes in groups of 3. So what to expect in terms of results, laboratory markers. This first table shows you the first column is the number of oocytes that we had donated to each patient. And you have here, you can donate 3, 4, 5, 6, 7, 8, so far, and so on. And then the second column is the number of cases that had this number of oocytes donated. As I said before, the majority of the cases have 9 oocytes donated. And what should we expect from these oocytes in terms of survivors? We should expect above rate. We need going to work. %. When I say blastocyst rate, it's usable blastocyst rate, not any blastocyst. These are blastocysts that are either destined to transfer, biopsy, or vitrification. This rate does not include blastocysts that are discarded. Then here are some numbers, so you have an idea of the percentage in each category of blastocysts, grade A, grade B, and grade C. The majority fall into grade B. And finally, this is a parameter that we really like to look at, which is the mean number of blastocysts according to the number of oocytes that were donated. And this is actually something that we use as a guarantee when we offer our oocytes. If you acquire a lot of such and such number of oocytes, you will have such and such number of blastocysts. So in this case, for that group of patients with number of blastocysts, so numbers in this table, just summarize. The overall survival rate, 90.8%. This rate, 57.6%. And if you offer a lot of 9 oocytes, you should expect around 3.8 blastocysts. Again, these are results in our clinic. More results, but represented in a different way. You have, again, the 3 big groups, 6 oocytes, 9 oocytes, and 12 oocytes. And then the light blue column is survival rate. The dark blue column is fertility rate. Fertilization rate. And the orange column is blastocyst rate. And on the lower part of this slide, you have the same 3 parameters represented in lines, but throughout the years. And even though you see slight shifts, it's very steady, which talks about the quality of us as an egg bank, but also of us as a fertility clinic doing IVF cycles. So, point number 4, and here I'm going to stop talking as an embryologist and what do I expect as an embryologist, and I will talk a little bit as founder of an egg bank and what do I like to offer our patients or our clinics abroad. And I like to offer quality in the logistic and a door-to-door service. There's a lot of bureaucracy behind all the work that we do. And you have to adjust to each country. In Argentina, we are based in Argentina. And in Argentina, fortunately, if you want to export eggs, all you have to do is request a permit to the Argentinian Ministry of Health. And for that, you just have to apply and send a donor consent and all the permits, the licenses of your clinic, your IVF clinic and your egg bank. And if you apply for this, it takes only 1 to 2 days to get that permit. So you have the permit and then you have to decide how you want to ship these oocytes. And there's two ways of doing this. You can do courier shipping or you can do in-cabin shipping. I use both. If you do in-courier shipping, there are some advantages. Of course, there's many companies and they do have the expertise. They do know how to handle cryotanks and they can streamline a service door to door, monitoring the tanks at all time, the location of the tank and the temperature of the tank. They are more familiar with all the regulatory compliance. They know how to work with customs and all the regulations. And if you use a courier shipping company to ship your oocytes, this may cost you less stress and logistical burden. Why? Because you don't have to worry about the permits, you don't have to worry to coordinate things with the airline, etc. On the other side, there's in-cabin shipping, and this does also have advantages, which I really like, because you have direct control on your product. You never lose sight of the tank, and this can avoid or can diminish the probability of losing the tank or mishandling of the tank by third parties. And it allows you to give a completely immediate reaction if something goes out of control. It's potentially faster, yes, because you just book a ticket and you go. When you do courier shipping, they depend on the availability in the cargo area of the airplanes. And sometimes it could be less expensive, but this will depend most likely in the country of destination. If you ask me, I like both modalities. Some countries do not allow in-cabin shipping, but if the country allows in-cabin shipping, I really, really, really like this modality. And here you have me, not with one tank, but with two tanks. Okay, if the tank arrives to destination, there's different regulatory agencies. I just put some example of some of the countries where we deliver. Brazil has, for instance, Anvisa. Just to illustrate this point, Anvisa can be very challenging. Today in Brazil, if you want to send oocytes, if you want to receive oocytes, if a clinic wants to receive oocytes, you have to be an importer. So you not only have to have your license as an IVF clinic, but you also have to be an importer. So a lot of clinics, they don't know how to do this. They don't want to do this. So we decided to open an office there, and then we go there and we distribute. USA, on the other side, has other regulations, like there's FDA, and if you want to send oocytes from Argentina to United States, the donor has to be studied in an FDA lab. I mean, we are certified as an FDA clinic, but we don't have a blood test lab. So if the oocytes from our bank go abroad, the donor has to be tested and we have to ship the blood. And these are just some examples. But the message is that as an egg bank, you have to adjust to the regulatory system of each country. And some of them can be more challenging than others. Then the oocytes arrive to the clinic, and the next chapter will be a lecture from whoever is receiving these oocytes. But one question, and to finish the lecture, is this is a very common question. Does the transportation affect the quality and the outcomes that we will get from these oocytes? And to answer this question, we did a study a couple of years ago, and sibling oocytes from the same donor were used, part here in our clinic of origin in Argentina and the other part in two different clinics in another country. And although these are very few cases, it gives you an idea that the parameters are similar. The only parameter that we did get more blastocysts here in our clinic. But in general, I think shipping oocytes via courier or via in-cabin will not affect. I'm okay, and I don't think it will affect the quality of the oocytes. So I think, and I hope that by the time you are listening to this, I'll have landed, I'll have my suitcases, and I'll have my headphones, and I will be able to answer questions. If not, here is my email, and I'll be happy to answer questions by email. Thank you very much.
And thank you to Dr. Natalia for the excellent presentation. It was indeed very insightful. As she mentioned, she may be able to join us for the Q&A session later. And I'm very pleased to now present to you our next speaker. Please welcome Dr. Peter Fuzesi. Peter brings over 20 years of expertise in reproductive medicine to his roles in CEO of Asian Egg Bank and COO of Hayabusa IVF in San Diego, California. Peter holds a Bachelor of Science in Biology and a Master of Science in Embryology and Andrology. He began his IVF career in New York as a lab supervisor and manager, later moving to San Diego in 2015 to focus on leadership roles. He co-founded Asian Egg Bank and serves on the board of directors for the Association of Reproductive Managers. Thank you, Dr. Peter. You're welcome to go ahead.
Thank you. Thank you, Skye, for the introduction. I appreciate it. And I'm starting up my slideshow. And welcome, everyone. My name is Peter Fuzesi. I'm from San Diego, California with Asian Egg Bank. And thank you for the opportunity to be part of the International IVF Initiatives webinar. The last session of the Battle of the Egg Banks will address the global market of egg banks and also the marketing of an egg bank. And this is an image I asked for the help of ChatGPT to create a logo for the theme. This is what AI thinks is the Battle of the Egg Banks look like. My disclosures, I'm the shareholder and executive of Asian Egg Bank and also an executive of Hayabusa IVF and California Fertility Experts. These are my references. I'm using this throughout my slideshow. And first, I wanted to start with reviewing the global market for donor eggs. These numbers are not specifically for egg banking, but overall donor egg IVF market size estimates. As you can see, globally, the market will have a 9% annual growth rate, reaching a $6.5 billion market size in 10 years. Meanwhile, the US will have half of this growth rate, going from $400 million industry to a $620 million by 2034. There has been a significant shift from fresh matched egg donation to frozen donor egg utilization since 2012. Let's take a look at this. This retrospective review paper published last year analyzed donor egg embryo transfer cycles from 2013 to 2020 on a national level in the United States. Over 135,000 embryo transfer cycles were completed. And as you can see in graph 1B, there is a significant increase of using frozen embryos, 42% to 77%. And the last graph, 1C, is showing fresh embryo transfer cycles, and the proportion of using frozen donor oocytes increased from 20% to 68%, while fresh oocyte utilization decreased from 80% to 32%. The paper also analyzed the clinical outcome of transfer cycles performed from 2018 to 2020. Over these 2 years, 48,000 donor oocyte embryo transfer cycles were completed. Live birth rates were lower with frozen compared to fresh donor oocyte for both fresh and frozen embryo transfer cycles. Although frozen eggs were associated with a slightly reduced live birth rate, rates of term healthy birth weight among singleton live births were comparable between donor oocyte states. This figure indicates that frozen donor egg embryos represented a significant portion of the donor egg transfers in the US. I don't have a similar figures for the rest of the world, but I'm sure there was a similar trend to observe. So what are the drivers for the growth of egg banking? Most importantly, the freezing technology. Vitrification enabled a better recovery for egg and embryo freezing. The concept of frozen donor egg banks is relatively recent in the field of reproductive medicine. While sperm banks have been around since the 1970s, 80s, egg banks took longer to establish due to the technical challenges with egg freezing. Slow freezing had a limited oocyte survival and quality after thawing, but with vitrification, we can achieve a 90 to 95% recovery of the frozen egg. The first known use of frozen donor eggs dates back to early 2000 as vitrification began to replace slow freezing methods. The first commercial donor egg banks appeared around the 2010s. Donor Egg Bank USA, founded in 2012, was among the pioneers in scaling this concept in the United States. Not coincidentally, the same year, the experimental label was lifted from the oocyte and embryo vitrification in the United States. Specifically, the American Society for Reproductive Medicine declared in October 2012 that egg freezing should no longer be considered experimental. This decision was based on the growing evidence showing that vitrification provided similar pregnancy rates and outcomes compared to using fresh eggs. Embryo vitrification by this time had already been adopted widely, with many clinics using it for years, but egg freezing status was under more scrutiny. The removal of the experimental label allowed us for a greater clinical use, including elective egg freezing and donor egg freezing as well. This technological achievement allowed us to create the first donor egg bank similar to sperm banking. Another important driver of growth is the rising infertility rate, specifically the increase in the number of women delaying childbirth due to career or personal choices. More and more intended parents are seeking fertility treatment cross-border, another driver for growth, which is due to either seeking more affordable treatment by traveling or looking for a fertility treatment option that is not available in their country. LGBTQ couples or single parents also increasing the demand. And overall, there is an increased convenience and cost effectiveness using donor egg bank. Frozen donor eggs allow for more flexible scheduling, eliminating the need for waiting for a donor or synchronized donor and recipient cycles. And frozen egg cycles can be less expensive due to the shared cost of coordination and medication. With broader accessibility, the availability of frozen donor eggs has expanded options for recipients, including those in areas with limited access to fresh donors overall. So what is enabling donor egg banks growing globally? Most importantly, access to third-party care is limited in many countries. Not only egg donation and surrogacy care, but even for certain IVF treatments. Germany, for example, freezing of oocyte is generally not permitted under the law. You can only freeze zygotes, and this restriction aims to prevent probably the creation of surplus embryos and to tightly control embryo usage. In Italy, egg freezing is allowed for both medical and social use. You can freeze embryo, but is subject to regulatory oversight. The use of PGTA, pre-implantation genetic testing for aneuploidy, in Europe varies significantly from country to country due to the different legal, ethical, and regulatory environments. Western Europe, mostly in Spain and Belgium, this is more permissive and it's highly used. Central and Eastern Europe, Czech Republic, for example, there is a growing use and generally permissive. And then there are countries, Germany, Italy, Austria, which is more restrictive due to the legal and ethical frameworks. But let's talk about egg donation. In Western Europe, most countries like Spain, Belgium, and UK have a well-established egg donation programs. Meanwhile, Germany, Switzerland, and in some Nordic countries, there is still a ban or heavily restricted. Cross-border reproductive care is common, with patients traveling from restrictive countries to a more permissive countries for egg donation. And I would like to zoom out a little bit to think about egg donation as part of a bigger picture. Donating gametes is a subspecialty within the broader organ and tissue donation industry. In the United States, the FDA categorizes gametes as HCTPs, human cells, tissues, and cellular and tissue-based products, which is including bones, ligaments, cornea, heart valve, and so on. In most countries, compensation for organ and tissue donation is strictly prohibited, especially when it involves vital organs like kidneys, part of the liver, or hearts. This is to prevent commodification of human organs and ensure that donations are made altruistically, not for profit. However, certain types of compensation are reimbursable. There are reimbursable items and certain type of compensation. This is like travel expenses, lost wages during recovery, or medical costs not covered by insurance. For example, in the United States, the National Organ Transplant Act prohibits the sale of organs for transplantation, but allows for reimbursement for expenses directly related to the donation process. For tissue donation, such as blood, bone marrow, or egg donation, regulations are different. For blood donation, generally donors may receive minimal compensation through it's mainly voluntary. For bone marrow, typically uncompensated in the United States, though there has been some debate and legal changes to this. Egg and sperm donation often compensated to cover time, efforts, and related expenses, and they are not classified as organs under most laws. It's interesting, I came across that Iran is the only country where monetary compensation for kidney donation is legally permitted. And this policy actually has significantly reduced the waiting list for kidney transplants in Iran. So here is a summary of some countries allowing or limiting egg donation and donor compensation. Legal and compensated egg donations are in Spain, in the Czech Republic, in the United States, India, Argentina, Mexico. At the same time, there are several countries where it's legal to do egg donation, but compensation is limited to a certain small amount to cover expenses. And there are also a lot of other countries where egg donation is prohibited or restricted. So we discussed most of these items already, but I wanted to summarize what are the key factors that enable the establishment of egg banks. Number one, the technological development, vitrification. Number two, the country where the egg bank is located should allow compensation or at least reimbursable expenses for egg donation. Number three, the other factors that is more and more studies are showing and proving that the outcomes are for success rates are comparable to fresh egg donation. While fresh donor eggs have slightly higher success rates, the gap has narrowed due to the technological improvements in egg freezing and thawing process. And also, there is a growing need. There is a market for egg donation that is readily available to clients and it's cost effective. As egg banks were established for a domestic market, there is an opportunity for them to grow into a global operation. This is allowing egg banks to provide cross-border care for clients. In a sense, this can be considered as a reverse health tourism. Frozen eggs can be shipped to the patient's country, so they wouldn't have to travel to access affordable egg donation. So what are the key challenges in global donor egg banking operations? Number one are the ethical and legal considerations. There are varying national laws on egg donor compensation, anonymity, and usage rights. We need to consider ethical debates around donor exploitation, especially in lower income countries. Also, there is a need for transparent, informed consent process and donor rights consideration. Another big challenge is the regulatory hurdles for global operation. Cross-border transport of donor eggs require compliance with local authorities. The egg bank has to satisfy the receiving country's regulatory oversight in donor testing, screening, processing. This is where the big names FDA, Health Canada, HIPAA, or ESHRE comes into play. There could be import-export restriction based on genetic testing, donor anonymity laws, and tissue handling standards. And also, it can be quite challenging to align all your SOPs across many different jurisdictions. There could be supply-demand imbalances for egg bank, and this could be due to some limited donor pools that the egg bank may have in countries where a high demand for egg donors for older maternal age population, like Japan, Italy, or United States. And there are niche needs, like specific ethnicities, which is often underserved. There are competition among clinics and banks. Local clinics increasingly establishing in-house egg banks to reduce reliance on third parties. Also, the global players face pricing pressure from regional competitors. But this could be counteracted by differentiation through technology, your donor matching algorithms, or patient support services. We also need to overcome cultural perceptions and patient education gaps. Donor egg IVF still carries stigma in many parts of the world, in Asia, Middle East, and Latin America. There is also a misunderstanding about donor anonymity, genetic influence, and success rates. We need to think about multilingual, culturally sensitive education materials for patients and donors. I also wanted to talk about egg donation trends in the United States and globally. There is no more anonymity in gamete donations. Due to the direct-to-consumer genetic testing, facial recognition software, the widespread use of social media. There is a movement in the reproductive field, and not only in the United States, in many other countries, to relabel the term anonymous egg donor. In the United States, we call it nowadays non-identifying donors. However, the terminology is not standardized nationally. We could hear open ID donor, semi-open, or ID release donor options. Each of these interpretations could vary between donor programs. In many US states, started to control egg donation. Just recently, Colorado State passed a legislation controlling egg donation overall. Currently, to Colorado, only open ID donors can be distributed. And the donor conceived person at age of 18 has the right to know the donor's identity. There are a donor contact and medical history follow-up requirements. Every 3 years, donor programs should follow up with the egg donors, at least with 2 different methods, and they have to document this. There is also a limitation on the number of children conceived with the same egg donors, to up to 25. There are requirements for permanent record keeping. And there are also a newer generation of donors who would like to keep in touch with the parents receiving donor gametes. Several notable changes can be expected in the egg banking industry. One, we can do advanced oocyte selection. Beyond the traditional maturity and morphological evaluation by a trained embryologist eye, we could see AI-driven oocyte assessment. Several companies already offer this technology. Some egg banks already offer additional genetic certification for donor oocyte. This technology directly addresses the risk of genetic errors by performing chromosomal screening on polar body. Another technology that is implemented at more and more egg bank is facial recognition. This utilizes sophisticated algorithms and machine learning to find the closest phenotype match to intended parents beyond traditional matching tools. Taking this to the next level, you can incorporate genetic and medical data information to identify the most suitable donor for each recipient. Ultra-fast vitrification and warming is being utilized in an increasing number of clinics. It's already used for embryos and is currently studied for oocyte freezing application. The beauty of the ultra-fast warming for embryos that you can utilize this even if the embryo was frozen with traditional vitrification process. This UFV approach also shortens the overall time it's required for the procedure, making it more convenient for clinics and patients. Our program here in San Diego collaborated with Mitch Sheep's team in Los Angeles to test ultra-fast vitrification for oocyte. This paper was published last year. The result is that overall survival rates were higher, an average of 98% for the ultra-fast vitrified and rapid warming oocyte compared to with conventional vitrification and warming control group. As the conclusion of this paper, this approach is more time efficient and consistently yields a higher survival rate, thereby potentially creating more embryos to use. We should proceed with strategic clinical trial applications, and this can ultimately enable commercial egg banks to adopt this technology. I also wanted to spend some time to discuss egg bank marketing. On the top of my list is that we have to be transparent in our data. Publishing our data on our success rates, donor screening, and lab protocols are important. We should keep our certifications shared and displayed with customers. And consistency is a key here. Highlighting case studies of reliable outcomes across clinics help to build this trust. Number 2, digital presence. This is non-negotiable. Your website and social media are key here. Search engine optimization, SEO for your geographic area, running Google Ads campaign. Also social media, Instagram and Facebook for your donor recruitment and LinkedIn for your partnership clinics. Testimonials are not easy to collect, but it's possible to have patient testimonials published. Educational outreach is another element that I wanted to emphasize once it comes to the marketing of an egg bank. This helps promoting your egg bank and building your brand. Create a webinar, for example. You can partner with an REI or fertility influencers, or you can create a podcast, let's say, for example, with donor conceived child. Your blog content could cover donor selection tips, new technology, or success stories. You could also provide wide labeled educational materials and training to partnership clinics. And as you are building your egg banks globally, it's important local partnership, aligning with regional IVF centers and agencies. A language adaptation, translating your website and materials into the target market languages. Regulatory compliance is also very important, emphasizing regional licenses and logistics capabilities. We need to emphasize the need to split your marketing efforts between 2 main groups, intended parents and donors. Different messaging, different platforms, and different KPIs to track. In addition to this, you have to consider your partnership clinics as a third group of your clients, which also need marketing attention. There could be a block in recruitment in the ability to identify possible donors online. There could be regulatory and social hurdles working against your marketing efforts. This is a US example associated with the strict abortion laws enacted in many states and how it's affected our marketing. When Meta, the so-called Facebook, Instagram, they got negative press for turning over abortion seekers' data to police in certain states where abortion is illegal. So the company significantly reduced its platform ability to market and measure the efficacy of advertising to people seeking any form of reproductive care, including egg donation. The result of this was that our egg donation ads were either flagged, and we needed to fine-tune the message, or we were completely in the dark who is getting those ads since data wasn't transparent. Overall, our ad targeting is now more broad and requires more input from our multicultural donor team to craft the message that will resonate with the intended audience. Ultimately, your ad bank and your brand positioning and the differentiators are playing the key role in your success. There are 3 items that I want to emphasize. Defining a unique value proposition. What makes your ad bank meaningfully different? Is it your success rates, your logistic process, your donor diversity, or offering hard-to-find ethnicities or mixed heritage donors? Maybe a screening rigor, what you can emphasize, genetic, psychological, and behavioral assessment that is exceeding industry norms. Donor pairing technology can be emphasized, matching algorithms or recipient interface tools. Number 2, standing out in the competitive field would mean to build a strong brand and brand recognition. What is your brand personality? Is it warm, professional, science-forward, or patient-centric? And also, storytelling is very powerful. Use your donor and recipient journeys to emotionally differentiate yourself. And number 3, aligning with patient and clinic needs. It's important to understand and speak to the pain point of patients and clinics. Patients, the clarity in process, financial transparency, emotional support. And to the clinics, reliable supply, minimal paperwork, rapid case setup, and seamless communication. So these are the 3 main positioning and differentiation that would help an egg bank to grow. So what are the key takeaways? Global demand for donor eggs is rising. There is plenty of opportunity for growth. Frozen egg banking is proven and is comparable in success rate to traditional egg donation approaches. Egg banks must adapt to regulatory landscapes and patient expectations. And also, effective marketing combines digital strategies, partnership, and trust building. Thank you for your attention. It's June and it's Pride Month, and this is our Asian Egg Bank Pride logo to celebrate diversity. I wanted to have a shout out to our wonderful team in San Diego, California. Thank you for your attention.
Dr. Fuzesi, thank you. We so appreciate your interesting talk. It was definitely a captivating contribution. So thank you once again.
Thank you, Skye.
I do have a question. Just give me a second, sorry. Specifically, how can a bank balance the need to find donors and to avoid exploitation?
That's a very good question. Thank you, Skye. I think it's very important that the egg bank is following the donor from the very beginning and having a close relationship with the donor throughout the onboarding process. During the application process, we always get in touch with the donor and make sure that the donor is fully onboarded to participate in the egg donation process, because before we allow the donor to complete the egg donation cycle. And we offer the donors and we follow the donors throughout the journey. We have many donors who are traveling from overseas, and to make sure that all of the arrangements throughout their travel are properly addressed, we take care of their flight ticket, their accommodation. During the accommodation, we never leave them alone. We always have a companion with them or somebody who is accompanying them from our company to make sure that they are participating willingly and they participating in this donor journey on their own will.
Amazing, thank you. Before we head on to the open question and answer session, I'd like to just welcome Dr. Yossi Unterslag and introduce him. Dr. Unterslag is a specialist in obstetrics and gynecology, having completed his undergraduate studies at the University of Pretoria and further specializing at the University of Witwatersrand in South Africa. Dr. Unterslag currently runs the donor egg program at Vitalab Egg Donation Agency, performing both frozen donor egg and fresh donor egg cycles. Thank you, Doctor. And I see that Dr. Natalia has also joined us. We will be posing some questions. And Jullin, over to you. If we can all have our cameras on and as well as our sound. Thank you.
Thanks, Skye. Wonderful talks from everybody. I agree. We'll open the session for Q&A now. So I'll start off with Dr. Natalia because we haven't had a chance to ask her anything just yet. I believe she may be in the airport. So we appreciate her taking the time to be with us. Dr. Natalia, who pays for the genetic screening? These mutations, testing for genetic screening can be quite costly. Who's responsible for this, the agency or the recipient? And this is a question from Hemraz. I believe I may be saying your name incorrectly, and I apologize.
Hi, everyone. I'm glad I made it. I told you I'm with my headphones. Sorry about the looks. I just had a 20-hour flight. We pay for the cost of the genetic testing for the donors. As I said in the lecture, if the patient wants to take advantage of this information, they normally pay for their part. But on our side, we cover the cost of all the genetic testing and all the upgrades necessary in the genetic testing for the donors.
Amazing. Thank you, Natalia. Maybe one more question to you, and then we'll pass it over to others. Do you have any live birth data from Davitri yet and utilizing that new system?
No, not yet, not yet. We started with Davitri last year, and we just got another 4 or 5 of those equipments. We do have info on blastocysts, as I mentioned in the lecture, but we don't have info on live birth yet. But if we do a webinar next year, just like this one, I will most likely have data on that.
Amazing.
Thank you.
Great. I have a question for Dr. Deanna. The question is, how is the matching process carried out in the majority of agencies?
So I think I'll hand this over to Dr. Yossi and Dr. Skye, who are very familiar with the process themselves. So let me hand over.
Sure. Thanks, Deanna. Thank you for the invitation to be here. It's been a great meeting. So in our clinic, we have an in-house agency. So we've got staff who are responsible for assisting patients with their matching process. We are a country where recipients can choose their donors. So they will basically shortlist their donors based on primarily physical characteristics. We will then send them donor profiles for donors that match their physical characteristics. They will then choose through them and make a decision, and then we kind of facilitate the matching process. So that's how we work. There are countries where it's a closed system. So we know that there are countries where the recipients do not get much information about the donor. But in South Africa, there's quite a lot of information that the recipients can see. The recipients have access to pretty detailed profiles. The only thing we don't allow in South Africa, which I know is allowed, for example, in America, under some conditions, are adult photos of the donors, but otherwise the profiles are very extensive and the recipients will choose whatever speaks to them.
Okay, and another interesting question that I will ask it to you now is, how about that situation that someone have frozen their own eggs and then they decided they want to donate those eggs? Is this possible, and what would be the requirements?
That is a great question, and I think it was expanded on in that there are so many women who are doing social egg freezing today and then meeting their partner, conceiving without having to use their frozen eggs or choosing not to use their frozen eggs. So we certainly allow it in South Africa with the donor's permission. We do make their eggs available on our donor recipient platform. So long as the who was the patient now has become a donor is willing to furnish us with information for their profile, we do make the eggs available. And it's becoming more and more popular in South Africa. We're getting requests very often now from patients who would like to donate their surplus eggs. And it's not only when women do social egg freezing. When you've got a woman who's doing IVF, where there may not be an egg quality factor, and it's maybe a male factor or a tubal factor, and they're a young woman and they are very good candidates and they stimulate well and they have surplus eggs, they are starting to offer their eggs to the recipients. So that kind of is an egg sharing process, and it's becoming more popular, and I think it's a great way to expand the donor egg banks.
I agree with that. Thanks a lot for the answer.
Yes.
Yannis, you're
I think you're
muted.
muted.
Yannis.
Yeah.
Sorry, I apologize. I would like to ask Natalia a question. I see that we have a lot of questions regarding the use of violet. Could you, based on your experience, could you please provide some more details on the science behind violet scoring? Are some morphological parameters like SER or granulation or other abnormalities reflected in the score? This was a question placed by Anna Gorbunova from Canada.
Okay. Hi again. In terms of the science behind, there's a lot of parameters that us as users don't know. But basically, as I mentioned in the lecture, there's this automatic segmentation of the oocytes in these three masks that are mainly the ooplasm, the perivitreal space, and the zona pellucida. And I mean, the newest version, as far as I understand, and of course, this technology is all the time updating itself, but the newest version combines three predictor models into an output variable. What I can say in terms of, in addition to the technology behind it, is that when we use this technology, what I'm seeing is that we have to learn a lot about its advantages, but at the same time, we are giving a lot of feedback in terms of the consequences of using this technology on a daily basis in the lab. What I'm trying to say is, for instance, you have to take pictures of the oocytes. If you take them one by one, this makes the whole procedure longer. Okay, so we give this feedback, and then Future Fertility comes back with a new tool. Now you're able to take pictures of all the oocytes at the same time. And this is just one of the examples. So we do learn a lot about the biology behind it, but we have to learn a lot about the practical issues with this technology as well. I'm not sure if I answered the question deeply, because I'm not so familiar in the biology behind the technology. I mean, granularity in the cytoplasm, is it covered? Well, I don't know, honestly. Maybe Rafa or the people from Future Fertility can answer that. But I know that they are taking in consideration a lot of variable that us, with our bare eyes in the bird microscope, for sure cannot see in the oocyte.
Yeah, I had the same idea too. And maybe I can ask another question on how you use this technology. I mean, who decides whether to offer the technology, the recipient, or you, when you...
For the egg bank, is us.
Create the eggs during the egg bank.
Yeah. For the egg bank, is us. We decide to do this for our own information. But for fertility preservation, is the physician informs about this tool to the patient, which is very interesting, because the one procedure in our clinic that grows every year, it's fertility preservation. Each year we get 20% more cases of women choosing to preserve their fertility. And this is a very useful tool, because with this information, you can tell the patient, look, you had, I don't know, let's say 8 eggs. And this is what you can expect from these 8 eggs. And then you decide if you want to do another round of 8 eggs or 10 eggs or whatever. So for donor eggs, we choose, we decide. For fertility preservation, is the physician recommending this to the patient, and is the patient who decides.
Thank you.
You're welcome.
I'd like to ask Dr. Peter a question, please. What is your policy on co-parenting, where 2 or more heterosexual people choose to start a family?
So we are working with single individuals, with married couples, with heterosexual couples, and gay couples. We are not limiting our services to certain patients. If the patients co-parenting, my understanding is this is a couple, they may not be married. We wouldn't limit that. Most importantly, we respect their choice. We have to still follow our consent form processing. They have to sign the initial forms to purchase the frozen donor egg batch. But eventually, we are shipping out this specimen to the IVF clinic, and we would like to defer the ultimate decision, how is the medical consent form to create these embryos, and also the disposition of the embryos, which is signed at the time of the IVF cycle, whenever they're creating the embryo or the embryo transfer. The disposition about the cryopreserved sample, it's on the shoulder of the IVF clinic receiving receiving the frozen egg from us. And that's what's very important, and it's spelled out clearly who has the legal rights over of those embryos, and also can be used later if there is any dispute arise.
Thank you so much. Another one, if I may. You have touched on it in your presentation, but I'd like to ask, would it be better to ship the sperm to you, fertilize the donor eggs, and then ship the resulting blastocysts to the intended parent's clinic?
Absolutely, this is one of our services, and I think many other egg banks are offering this service. There are clinics who may limit receiving frozen egg, but they are from other egg banks, probably because they have their own internal egg bank. And therefore, they are okay to receive embryo. So the patients would send a specimen to us, frozen sperm. We create the embryo here in our clinic, and the created embryo can be sent to the patient desired IVF center. So they can complete the embryo transfer with their trusted physician.
Wonderful. Makes sense. Thank you, Jullin. You're welcome to take the floor.
Thank you. I'll ask a question for Dr. Deanna or any one of her colleagues here. It's a question maybe on sort of the demographics of the donors that are in South Africa. One part of the question is, is there a shortage of donors? Did you have ample donors there? Or is there like an excess of a certain demographic? Or do you have donors that come in from around the world potentially to your lab and clinic? Can you maybe fill us in a little bit regarding that?
I'll start off and then let Dr. Guidozzi continue. So we do have a lot of international patients, so from other parts of Africa and even from China, who do come through to our unit to try and make use of our services. So we definitely don't have enough Chinese donors. We have a lot of African donors, which is very helpful, obviously, in our setting, but we also do have a lack of Caucasian donors. So I'll pass on to Dr. Guidozzi to continue finishing off on that information. Yeah,
I think that's correct. So as per the demographics of our country, the majority of our country is African race. So we have huge access to eggs of African race. We do struggle with Caucasian and Asian patients, and like Deanna says, a lot of our patients come from outside of South Africa. So we are always looking for eggs from other egg banks, particularly Caucasian Asian recipients looking for eggs. And we're comfortable to work with egg banks from all over the world. We do receive eggs from other egg banks. We don't have donors traveling to South Africa to donate in South Africa. I think probably primarily because our compensation is very much targeted economically to South Africans, and our currency is not very strong, which makes coming to South Africa very attractive for recipients, but not for donors, because they'll be compensated a very minimal amount compared to what they're compensated in America or Europe. So that's really kind of how we work.
Amazing. That makes sense. Rafael, I'll pass it to you for questions.
Yes, I have one question for Dr. Peter. And the question is basically, in this new era of new technologies, and considering how, how much people working on egg bank to recruit donors, how much can the recruitment, how much can be the recruitment done in an automatic way? What would be your opinions on that?
Yeah. I mean, many programs, donor banks are relying on digital advertisement as a first layer in donor recruitment. But there are other recruiters that can be considered. We know that many egg banks are incentivizing former egg donor or current egg donor to bring additional egg donor if their friends, somebody who would consider to be an egg donor as well. And once they complete the cycle, the recruited egg donor can be considered an incentive for the referral. That's one way of extending a network and bringing additional egg donors on board. That wouldn't be an additional burden on the clinic. It's just a marketing tool, how we are trying to increase our donor applicants. Donor application itself can be automated, and there are various programs out there that the egg bank can utilize, so the application form itself doesn't need to be reviewed manually. Rather than there are flags, yellow, red flags can be placed into the application form, and that can automate the application part of the egg donor recruitment.
Great, makes sense. Thanks a lot. I'll pass it on to Yannis.
Thank you. I'll ask Natalia again. Hope she's still at the airport. Could you unmute, Natalia? Okay, great.
Yes,
Thank
I'm
you.
here.
So what about compatibility of vitrification and thawing media that are commercially available? From your experience as an egg bank when sending eggs to different clinics, what do you suggest to this clinic in terms of thawing media? Are you in favor of this universal warming protocol, or you suggest to use the same vitrification?
I'm in favor of whatever works for everyone to begin with, but I will always recommend our recipients to use the same media as we use. Now, I don't know if I can use commercial names here or not, but it doesn't matter. I'll use A and B. I've cryopreserved with a very well-known vitrification media A, and had to thaw with a very well-known commercial thawing media B, and it worked well. So this is information that I have from my experience in my clinic. So when I send the oocytes abroad and the recipient clinic has a different media, if I know if we're talking about the same two medias, it's okay. Although I will always recommend using the same media. Now, there are other countries that have like local medias, and then I cannot guarantee the same results with not commercially media. Am I being clear?
Yeah, absolutely, absolutely.
Yeah. And another thing that I wanted to comment, since we are talking about automatic technologies, because there was a question in the QA section and I did answer it. but I can answer it here. We are also facing some challenges trying to combine different technologies. I mentioned Violet and I mentioned Davitri in my lecture, and I'm more than welcome to both of them. But sometimes what works best for one of the technologies can somehow impair the other. So we are all working very actively to make sure that we can combine technologies and take the most advantage of each one of them.
Exactly, and maybe test it in your own setup and confirm.
Yes. Because I'll just give you a quick example. For us as embryologists, we do like to take pictures very quickly for Violet. Perfect. That means that I have to freeze all the oocytes according to Violet in Davitri, and sometimes this is okay. But then I have to match these oocytes with the recipient, and sometimes the recipient wants more oocytes than the ones than the group that I set with Davitri and with Violet. So this is something that when you start using these technologies, which is amazing, you start facing also these problems. But it's nice that we are all working very positively to make sure that we can use all of them in the same lab.
Great, thank you.
You're welcome.
Jullin,
Yes.
is there another question for our presenters?
I myself for Skye, I think we're limited on time, but maybe one or two more questions.
Okay.
General question, and maybe this would apply to everybody actually, but could an egg bank, I suppose, start acting as more of a repository? There's a lot of frozen material in IVF clinics. Are there thoughts of egg banks, helping to manage this surplus of frozen material? Does that make sense, Dr. Guidozzi?
Yeah, so we certainly have quite a lot of embryo donation in South Africa, which I think is kind of what you're talking about, where families have completed their families and they've got surplus embryos, and a lot of them are turning to embryo donation, which is fantastic, because to try to donate an embryo as opposed to discarding an embryo is so much better. So it's certainly becoming more and more common in our unit, and it's certainly something that I would encourage all units to look at, giving a couple an opportunity to have a pregnancy where they may not have been able to. It's fantastic.
At the same time, I think that it would be a huge challenge for an egg bank to take on long-term storage responsibilities, where patients are storing for 2, 3, 5, 6 years, and then they would want to use the specimen again. There is a lot of follow-up with patients for billing, consent forming process, and with the clinics. If the egg bank is willing to branch out and take on additional responsibilities, but I don't think that this is well aligned with the initial goals of creating an egg bank.
That was actually going to be my last questions for you to wrap up the session. Like, what would be the main challenge an egg bank will be facing? But you just answered part of it. I don't know if you would like to add something else before we close it.
I think the liability is huge. That's why even IVF clinics would like to shift this burden. I'm sure they would like to keep on the revenue, but the follow-up, and there are many patients that they are either lost touch with, or patients are not willing to pay they are not paying the storage fees. At the same time, the clinics feel risky just to discard these embryos without proper consent forms, and to shift this liability to egg banks and to take on, it's a huge undertaking. Not impossible, but I think it would create a distraction for an egg bank from its core operation.
Great. Well, I think it's a good way to wrap up. As you know, this session is being sponsored by Future Fertility. We would like to thank all of you who took part in this webinar. My co-hosts, of course, Skye Green, Yannis Panagiotidis, and my colleague. I work with her every day. So my colleague, Jullin Fjeldstad, and of course, the presenters. Thanks a lot to Dr. Deanna Guidozzi from Vitalab Egg Donation Agency, Dr. Natalia Basile from WeBank and WeFib in Argentina, and Dr. Peter Fuzesi from the Asian Egg Bank. It's been a real pleasure. And yes, I'll pass it on to Jullin.
Thanks, Rafa. Thank you to you too. It's been a pleasure to listen to everybody and to co-host with you, Rafa. And let's not forget the amazing I3 team. They're the organizing committee of this initiative. And the people responsible for putting on these webinars include Jacques Cohen, Peter Naj, Marianne Civites, Thomas Elliott, Fran Farley, Violetta Sura, and the one and only Giles Palmer. And please join I3 next week for another amazing webinar. It will be an RBMO Live session, and they'll be presenting the Robert Edwards Awards for the best paper from last year. So don't miss it. Thank you, everyone.